It is my pleasure to introduce Devin Hawkins, who is an assistant professor of public health at the Massachusetts College of Pharmacy and Health Sciences, where he also serves as the director of the undergraduate public health program. He conducts research on occupational health and health disparities. He will be presenting Characterizing Violent Injuries to Inform Prevention Among Healthcare Workers. Professor Hawkins, the floor is yours.
Well, thanks. It's a real pleasure to be speaking with you all tonight. As Kevin just said, I'm going to be talking about characterizing violent injuries to inform prevention among healthcare workers. And before I get started, I just want to mention two things. First off, this is very much a work in progress. It's really an exciting project that we're working on to try to identify the characteristics of these violent injuries amongst healthcare workers. And we're sort of in the middle phases of that right now. And this is very much a group project. So I'm presenting the findings, but this project wouldn't have been possible without some of my colleagues. Sundar Siddiq, who has done a lot of the work for the analysis that I'll be talking about, particularly looking at the qualitative records and trying to identify characteristics. Chris Pontus, who we're fortunate to have joining us tonight, and Judith Pare, who both were with the MNA, who were really vital to getting this project off the ground and then also helping out with the data collection side of things. So the motivation for this project was something that I think a lot of you who are joining tonight are familiar with. Workers in the healthcare industry are at an elevated risk for work-related violence. This is showing data from the Bureau of Labor Statistics, their survey of occupational injuries and illnesses for 2021 and 2022, the most recent years, with data available. And it's showing the violent injury rate. And you can see by far the highest rate is occurring amongst healthcare and social assistance workers, with about close to 15 injuries per 100,000 full-time workers in this group. And I should clarify, this is the most severe injuries, those that are resulting in days away from work, job restriction, or job transfer. And it's well known that data from the Survey of Occupational Injuries and Illnesses is very much an underestimate. So the actual burden is probably substantially higher than this. Additionally, even before the COVID-19 pandemic, the rate of violence in healthcare was increasing. So this was a study that I worked on with some colleagues for data from 2011 to 2017. It's almost 10 years old now, but it was looking at trends in violent injuries. And we very much saw that the trends were increasing for both the healthcare industry overall, about 5% per year, and then also for different healthcare occupations, for healthcare practitioners and for healthcare support workers. Both groups had increases in their violent injuries, annual increases. And as I'll show you in just a minute, this has continued since COVID-19 as well. We also see differences in risk by occupation and industry. So this is coming from the same paper that looked at rates by industry sectors and also occupation sectors. So we see in particular very high rates in nursing care facilities and also in residential care without skilled nursing, some of the highest violent injury rates. With respect to occupation, we see very high rates amongst nurses, definitely, and then also amongst nursing, psychiatric, and home health aides, and then occupational therapy and physical therapy assistants and aides. So there's a risk across industries and occupations, but I'm just highlighting these as being some industries and occupations, specific industries and occupations that have very high rates. These violent injuries also contribute to health disparities. In particular, we see higher rates amongst Black healthcare practitioners and healthcare support workers. Amongst healthcare practitioners, the rate of violent injuries is actually 3 times higher. That's what this number right here is showing. The rate of violent injuries is 3 times higher compared to white healthcare practitioners. And then amongst healthcare support workers, the rate for Black healthcare support workers is 42% higher than that for white healthcare support workers. As I said, though, I showed you some of the earlier trends, the pre-COVID trends, and this has continued post-COVID-19 as well. So this is just showing the number of violent injuries amongst healthcare workers between 2011 and 2024. They have changed how the data is published from the Bureau of Labor Statistics recently, so the comparability, especially for the later years, is a little bit more difficult to determine, but we do still see these increases that have seemed to have sped up during COVID-19 and have really continued since then. Working with colleagues from the Massachusetts Nurses Association, we also looked at some of these patterns specifically in Massachusetts. So this is showing data about the median days lost from violent injuries for Massachusetts healthcare workers between 2017 and 2020. And we see a big jump that happened in 2020, whereas before it was somewhere between 4 to 6 days lost per injury, or the median days lost per injury. During COVID-19, that went up to 9. So it's not just the numbers were increasing, but also some evidence that the severity of those injuries were increasing as well, because they were resulting in more lost days of work or more days away from work. This is showing these same patterns for nurses in particular, and you can see a much bigger increase that was happening there, whereas during COVID, it was close to 30 days lost for the median injury. So this is important because there is a substantial burden of violent injuries amongst healthcare workers. And then doing this work is also important because healthcare institutions have an obligation to protect workers from hazards, including violent injuries. So I have on the screen right now something that probably many of you are familiar with, which is the OSHA General Duty Clause that says all employers shall furnish their employees with employment in a place of employment which is free from recognized hazards that are causing or are likely to cause death or serious physical harm to their employees. And obviously, violence is a very easy to recognize hazard, and it is causing a significant risk of death. Even though I'm focusing on non-fatal injuries, we do see many fatal violent injuries that occur in the healthcare industry, but certainly physical harm with the high burden and also the high severity that we see with these violent injuries. And I think it's particularly important to highlight the OSHA General Duty Clause because there actually have been some threats against the General Duty Clause. This is part of the 1970 OSHA Act, so it's something that's instanced in law, but there's been proposals to interpret the law in different ways. For example, the current administration for OSHA has proposed identifying some professions or some occupations or industries as being inherently risky, meaning making a determination that there is not an obligation to protect workers in these types of situations because those jobs are inherently risky. And obviously that's a concern for a lot of different reasons because that could end protection for workers in jobs that might arbitrarily be defined as being inherently risky. And who knows if that could ever be done for healthcare workers. They say, no, this is just the nature of your job. There's no duty to enforce the standard at this time. I should say this is still just a proposal, but I just want to highlight it because it certainly is a concerning proposal. So that was just a little bit of background. So now I'm going to talk a little bit about the project that I've been working on with my colleagues. So an important component of preventing violent injuries amongst healthcare workers is understanding the circumstances of those injuries. As you're going to see, there's a lot of diversity in terms of what's happening when we're talking about violent injuries. What are the precipitating events? What type of violence occurred? Where did it occur? What was the state of the patient or the perpetrator of the violence in those particular instances? So with that, that really encourages us to try to say, okay, what are these characteristics? And then especially, how can we identify characteristics of these injuries that are preventable, meaning areas that we can intervene and do something about them? So the specific objectives of this project are to develop methods for extracting information about circumstances of violent injuries from natural language descriptions of injuries and illnesses. As you'll see, we use OSHA logs for this analysis, and the event descriptions in those logs can mean anything. They're a narrative about the injury, and they're really valuable pieces of information, but they can be difficult to extract information from because there's such a diversity and so many different components about the injuries that can be described. After we do that, we then want to use that information to assess the burden of violent injuries and trends in these injuries amongst Massachusetts healthcare workers. So we want to see what's happening with these injuries, look at the trends in these different characteristics, what's contributing to these injuries, and then examine the risk of occupational injuries trends by risk by injury circumstances and disparities in these risks. So again, characterizing what is happening and who's being affected by these violent injuries. So before I get into a lot of detail about the methods, I wanted to show you some examples of violent injury description. So these are real narratives about violent injuries that come directly from the injury logs. And they're ones that I think give a sense of all the diversity and all the different characteristics and the different elements of these descriptions. And that gives you a sense, yes, of how rich this information is, but then also about how it can sometimes be a challenge to use this information for analysis. So I'll just read this one. About 8:20 p.m., I knocked at a patient's door to give her nighttime medication. When I greeted the patient, she immediately jumped out of bed and began posturing towards me. I then began to back up to get away from the patient. When I got at the doorway, the patient began forcibly closing the room door with my right hand caught up between the door. I sustained an injury on my right wrist. Staff on the unit immediately applied ice pack, and I went down to the ED for further evaluation. A really rich description, obviously a horrible event that was happening in these circumstances, but we have information here about what was happening before the injury happened, immediately when the injury happened, what part of the body was impacted, and then also, and you don't always get this, what was the follow-up? What did the staff person do? What did other members of the healthcare team to try to help in these circumstances? So again, there's a lot of information here, but one thing I highlight, because this is a common theme that we see in a lot of the injuries, the time that the injury occurred, in particular for this one, it was a nighttime event while the healthcare worker was bringing medication to the patient. Another example, patient awoke from sleep to go to the bathroom. While ambulating, patient became combative and verbally aggressive. Patient pulled at RN shoulder while attempting to get the patient back to bed. Nurse admin is aware. at bedside for plan, security call to bedside, and placed patient in 4-point restraints. And then they had a sitter at the bedside. Again, a lot of information here. Another common theme that we see in quite a few of these is that they occur during ambulating, bringing the patient out of bed, taking the patient to the bathroom. In this case, we have indication of both physical violence and then also verbal violence as well. Third description, this patient became disoriented upon waking. You can see a similar theme here, a lot occurring upon waking. Waking up from anesthesia, she was swinging and quickly moving both upper and lower extremities. Multiple nurses and CRNAs were needed to help protect the patient from harming herself and others. The patient was forcefully trying to remove her IVs and clothing while assisting in holding the patient's extremities. I felt a twinge in my left knee from twisting and being put off balance. I noticed pain and slight swelling over the weekend. The discomfort has continued until today. And again, you see a very rich description here, what was happening before, what was happening during the injury, and then information about the long-term consequences as well. So something I highlight here in this case about a patient waking up disoriented. This again is a common theme that we see with these different injury narratives. Now, these are examples of narratives that do have a rich amount of information in them, but that is not always the case. There's a wide variety of descriptions that will be given and also different ways that different hospitals will present this information. So, for example, here's another one, bruised face, struck by individual, patient. So there's actually really useful information here, but it's not at the same detail level as some of the previous ones here. So we can see what part of the body was impacted, who caused the injury, but we don't get all this information about what was preceding the events, what happened afterwards that we get with these other descriptions. And so this is just to say that we wanted, as part of this program or this research project, to come up with a way of trying to extract as much information from, yes, these really detailed descriptions, but also these other ones that don't have as much detail about them. So a really flexible type of program that could get all this type of information. So what were the methods that we used for this project? So this was an IRB-approved project. Our data source, as I mentioned earlier, occupational health and safety 300 logs. And these have a lot of information in them other than just the injury description. They have about when the injury occurred, the location of the injury, the occupation of the injured worker, information about the median lost work days. But for this element of the project, I'm really just focusing on using these OSHA 300 logs. And these contain information about reported, and that's again something that's really important to note because so many injuries go unreported, violent injuries, but just occupational injuries in general that were occurring in Massachusetts, specific Massachusetts hospitals between 2021 and 2023. And it was staff from the Massachusetts Nurses Association that obtained this information, and we're really grateful to them for doing that work. Following data cleaning and reviewing this information, violent injuries were identified using SAS code provided by Stephen Burke, who's from NIOSH. So he was kind enough to provide us with a SAS code that actually does look at these event narratives and puts them into these broad categories of the nature of the injury. So in particular, we use that information to find out and identify which injuries were violent injuries. And then we went through and we manually reviewed them to catch some that might not have been identified initially. And so then we did an initial attempt to identify circumstances of violent injury using a large language model. And this was the part of the project that Dr. Sadiq did quite a bit of work on. So essentially what she did was she designed a schema where running a large language model, so an AI assisted model, she sought to extract information about key circumstances of violent injury. So the injury type, the body part that was affected, the event context, the location of the injury, what might have been the trigger for the injury, the patient state at the time of the injury, the team response, whether there were any objects used or weapons used as part of the injury, what was the outcome of the injury, and then whether any medical action was taken. So basically, she wrote a command to this AI model to try to identify the circumstances of the injury and pull that information out. And then I'll show you in a minute, this is where the stage of the project where we're at right now, identifying really granular, detailed aspects of these injuries, trying to put them into specific categories for these different variables, and then also trying to find underlying themes or commonalities between the different types of violent injuries. So just really briefly, so overall, we received data from 14 hospitals from 2022 to 2024. There were a total of 5,035 injuries and illnesses that were reported. This is all injuries and illnesses. And of those, 333 were violent incidents. And just to give you a little bit of information about these incidents, not all of them had usable occupation information, but I do show the ones that had usable occupation information here. So, for example, there were 119 violent injuries amongst nurses, 42 amongst techs, aides, and assistants, 20 amongst physicians, 10 amongst guards and officers, and 7 amongst janitors, cleaners. To the final column to the right, I show which percentage of the overall injuries that had usable occupational information were violence. And that can give you a sense of maybe which occupations might be at a higher risk. So, for example, overall, we saw 3.9% of the injuries were violent injuries. But for nurses, 9.2% of their injuries were violent injuries. And then also for physicians, we see 12.6% of their overall injuries were violent injuries. So again, this is this work in progress stage right now, but so we're trying to identify some, like I said, characteristics of the injuries. So I'm just giving some examples here. I'm not quantifying them right now because we're still working on figuring out, well, which specific categories do we want to use, and then how accurately is the model putting these injuries into these particular categories. But for example, when looking at injury type, some of the common ones we saw were struck by patient, and that could be divided up into being kicked or punched. We see many human bites that are occurring, grabbing, twisting as well. For body parts, some of the common body parts we saw were face, arm, knee, eye, and neck. And then for the event, this is some of the terminology that was being used. And so what we're trying to figure out right now is how are these things being distinguished from each other? For example, some injuries were identified as being assault by patient, some were struck by patient. What's the differences between those? We do see many that were related to preventing patient elopement. So when the patients are trying to flee and injuries that occur in those instances, we do include those in the violent category. And then many, like I talked about when I was showing you the examples about assisting the patient in different ways, taking to bed, taking to the bathroom. And then also the location. We do have a separate code in the OSHA 300 logs about the location of the injury. And actually, Chris is working on doing some analysis with that. But we also wanted to see what type of information could be pulled out directly from the injury descriptions themselves, because we also want to see how much they agree with each other. So these are some of the common locations that we saw for those injury locations. One of the aspects of this project I'm particularly interested in is looking into the escalation triggers, because again, we're doing this work with the goal of identifying aspects of the injuries that might be targets for prevention. So what could be happening before that might give a clue to there being a heightened risk for violence in different circumstances. So some we see, for example, patients acting aggressive beforehand, see pushing happening, the elopements like I was talking about. Also in situations where the patient is in a confused or combative state, agitation, those might be some triggers or clues to what might be triggering the violent incidents. Also, information about the patient's state. One thing that we're trying to do with this code is also have it identify when this information is not specified, because that is a big concern when we're doing this analysis, because as I showed you, there's different levels of detail in the descriptions we have. So we want to be acknowledging that a lot of what we're going to see will be underreported, because yes, in many cases, for example, they'll identify whether the patient was acting aggressive before the injury occurred, but in many instances, that's not the case. So we want to acknowledge that we're not necessarily being able to say what is the overall burden of how this represents these types of injuries overall. And then also, like I said, whether a weapon was used. And these are some of the common terminology that we would see be pulled out, just vaguely an object, a bedside table, bed rails, and in some cases, even an arm with a cast on it would be used as a weapon. So again, that was just showing you the really detailed categories, and we're still trying to really dig down into that and see how we're categorizing these, how we're distinguishing them from each other, and refining it. It's very much an iterative process where we're going back and forth. But also what this code was able to do was pull out some granular themes and say, okay, what are some common combinations we see between the different characteristics? So what are some bigger categories that these can be put in? So a lot fall into this category of violence during clinical task and routine care, violence during patient restraint and security events, events when weapons are being used, the patient's state being a complicating factor, being identified before. In some cases, we do see particular types of gender-based violence that will come out in some of the narratives that we're seeing when there's not information about whether de-escalation was being used. In some cases, there'll be staff members who are trapped in the room with the violent patient. So these are some common themes that we see commonalities that we see between different violent injury descriptions. And then these themselves can be put into larger domain categories. And there was 4 that were particularly identified: direct patient-initiated violence and assault, ergonomic and exertion related injuries during patient handling. So like the direct ones is like when immediately from the beginning there is aggression and violence occurring. The ergonomic and exertion related injuries are those that we see that seem to be precipitated by, for example, like we were talking about, moving the patient to the bathroom. Some contextual and situational triggers. So there were some situations where it's fairly specific to the event, what's triggering the violence. And then sometimes we see cross-cutting areas. So there's a lot of differences and they're harder to put into any of these specific injury domains. So that's where we are right now. Like I said, this is very much a work in progress, but there are some further steps we're taking. As I referred to, we want to continue to refine this qualitative analysis again to really understand how we're putting these injuries into these codes and then how we're categorizing them. We want to look at percent agreement between automatic codes and codes refined after review. So even though we're using this AI model initially, we're going back and we're looking at it and we're saying, okay, how much do we agree with the categories that these injuries are being put into? Eventually, though, what we want to do, because this AI code is very much a black box, we know what we're putting into it, we know what we're getting out of it, but we don't necessarily know what's happening in between. Ultimately, we do want to use these codes and then create a SAS code with it that could be permanently used and could be shared with others, meaning that it is something that we can see. We can see how the different terminology from the narratives is being used to put injuries into these categories. And then after we do that, then we want to test it on future data, particularly 2024 and 2025 injury data. So we can see, okay, we created this code using data from 2001 to 2023, but how well does it work with data for 2024 to 2025? And then we want to use these findings to produce a report about injuries amongst healthcare workers in Massachusetts. We want to make this publicly available so other researchers can use it. And then also, because I'm focusing on healthcare here, but a lot of other industries have also been seeing increases in violent injuries. The transportation industry in particular, also in retail as well. And so we want to see maybe some aspects of these codes could also be used to understand the circumstances of violent injuries occurring in other industries. I just want to end up by talking a little bit about prevention of injuries amongst healthcare workers, focusing a little bit on policy-based strategies. So one policy that I'll highlight is that California actually does have a violence prevention in healthcare standard, so a specific standard for preventing violent injuries amongst healthcare workers. And this has a few different components to it, having a violence prevention plan, identifying risk factors for workplace violence, similar to what we're doing for this project, correcting those hazards, so not just identifying them, but also doing something after identifying them, preparing for workplace violent emergencies, responding to the incidents, having a plan that's in place for multiple employers, keeping track of the violent incidents, and then also training employees about prevention. This was implemented, I believe, starting in 2019 or 2018. So it's been in place for a while now. And there have been some assessments that have looked at its impact. And so this is one study that did show a decline in the number of violent injuries occurring after the implementation of the standard. And so it does seem to be effective. In Massachusetts, there is a proposed bill to do something very similar for targeting violent injuries amongst healthcare workers. This has actually passed the House of Representatives back in November. It passed unanimously, and right now it's in the Senate. Interestingly, this morning when I was driving to work, there was a story on WBUR, which is one of the local NPR stations in the Boston area, that was actually talking about this proposed law. I'll talk about that article in just a minute, but just to say the components of the bill, a lot of it similar to the California bill, having risk assessment for violence in the hospitals, having a violence prevention plan, offering paid leave benefits for workers who were assaulted. And actually, one interesting thing about the law is that this is distinct from the paid sick leave. So it actually is a separate type of leave that's available to workers in those instances. Having financial penalties for violating the bill provisions for the healthcare institutions. And then also having stricter criminal penalties for assault that is done to healthcare workers. So like I said, there was an article, or I think a really interesting, a news story, an article about this in WBUR today. So I just added this at the end of my presentation here just to highlight it. I won't read this word for word, but I encourage everybody to take a look at it. But the article actually begins with something that I didn't talk about here, but this was actually a particular violent incident that occurred in an emergency room after a patient had a drug overdose that was reversed. It doesn't say it here, but I would assume this might have been a naloxone to reverse an opioid overdose. And when the patient woke up, which is very common after these types of reversals, the patient was aggressive and assaulted the particular healthcare worker. And in fact, if you see in the second paragraph, it says that this person actually threatened to come after the person's family in this instance. The article, one criticism I should sort of had of it was that it focused a bit more on the criminal angle of it. So, like I said, part of the bill is also to have stricter penalties for when these assaults happen to healthcare workers. And that's an important component. But again, from my perspective, and I'm sure from many of your perspectives, we're focusing on prevention, right? And so I think I would have preferred if that article highlighted a little bit more some of these aspects about the prevention side, having plans in place, having training in place. But I was happy to see that this was getting attention, especially since it's been a few months now since the Massachusetts House of Representatives passed this bill. And there also is a federal bill that has not really gone anywhere yet. So this is showing the current state. It's been introduced, but it hasn't gone through the House or the Senate. But ultimately, that would be the next step because obviously it's important. I'm very glad that some states have and some states are planning to have healthcare violence prevention laws. But we would want to see healthcare workers across the country, and especially since this is not a problem that's isolated to any particular states. The data that I was showing you at the beginning of this presentation was national data. This has been growing nationally. It was growing before COVID. It seemed to have started to grow at a faster rate since COVID, and it's continued since then. So there's a real need to address this issue. So thanks so much, everybody. This is just some information. I just want to acknowledge that this project was supported by a grant from the National Institute of Occupational Safety and Health, which is, again, I'm sure many of you know, is an incredibly important organization that's part of the CDC. And like I said, this work wouldn't be possible without the support of the staff at the Massachusetts Nurses Association. And again, I want to acknowledge Stephen Burke, who's from NIOSH, who provided the initial SAS code that was used for categorizing the injuries and illnesses from this study. So thanks, everybody, and I'd be more than happy to answer any questions.